Okay, now we'll talk about the clinical information about heart failure. We will begin with the symptoms. We have talked about many of the symptoms in the previous video, but here I would like to mention one that I didn't tell you about in the previous video, and that is the S4 gallop. This is usually heard when there is left-sided heart failure, especially in cases of pressure overload and diastolic dysfunction. To understand how S4 gallop develop, we must understand the filling of the ventricles. Actually, the filling of the ventricles is mostly passive. That is, during diastole, blood flows directly from the atria to the ventricles with a very little contribution to the atrial contraction. This is in a normal person. When the heart fails, the ventricular filling becomes more dependent on atrial contraction. So at the beginning of diastole, the ventricles will fill passively, and when diastole approaches its end, the ventricles are not yet filled with the blood because they are non-compliant. They are not receiving the blood well. So this will initiate the atrial contraction in order to force the blood towards the ventricles. This atrial contraction is responsible for the S4 gallop heard in left-sided heart failure mainly. Okay, now if a patient presented to you with one or a collection of these symptoms, we said that you should put heart failure at the top of your differential diagnosis list because it is a clinical diagnosis. So now you start your workup, you order your tests. The first test to order in such a patient is BMP. BMP is a peptide hormone, peptide substance. Its name is brain natriuretic peptide, and this was named like that because it was first discovered in the brain, but it is actually released from the ventricles. And natriuretic means that it increases sodium diuresis. So this substance is released from ventricles, and its level increases when there is stretch by volume or pressure overload. And this what occurs in heart failure. This test is actually a sensitive but not non-specific test. When the level of the substance is very high, very high, it becomes specific for heart failure. But when it is moderately elevated, it is not specific because some other conditions can result in its elevation, like acute renal failure. But when this substance level is low, this means there is no heart failure because it is very sensitive for heart failure. Okay, now you make an ECG for the patient. The ECG is helpful in the diagnosis of heart failure because it gives some clues about the causes of heart failure. For example, there is left ventricular hypertrophy, which, for example, occur in patients with long-standing hypertension. This will appear in the ECG. Also, a clue of an old infarction, which may precipitate heart failure, also can appear on the ECG. Okay, and then you order your chest X-ray. Chest X-ray is very helpful in diagnosis of heart failure, especially the acute exacerbation of heart failure. Actually, there are 5 diagnostic signs of heart failure that may be seen on chest X-ray, and these are the A, B, C, D, E. The A stands for alveolar edema. This will present as lung hyperinflation. This is called batwing appearance. The B stands for curly B lines. Curly B lines are actually horizontal lines that are seen at the costodiaphragmatic angle because of increased thickness of the interalveolar septa. This interalveolar septa will increase its thickness because of the pulmonary edema. The fluid is, the lungs are filled with fluid, and this will fill the interalveolar septa. The C stands for cardiomegaly, and that is enlargement of the heart. This is especially common for patients with a pressure overload, as we said, like those with long-standing hypertension. Cardiomegaly is measured by measuring the ratio of the diameter of the cardiac salute to the full field diameter. When this ratio is more than 55%, there is cardiomegaly. The D stands for dilated pulmonary arteries, and this is obvious because of the backup pressure and the rush of fluid back towards the lungs. The A stands for pleural effusion, and this is seen in cases of severe heart failure. And these are some images that can show the ABCDE of heart failure. Those are the curly B lines. These are normally not present, but when there is pulmonary edema, there is increased thickness of interalveolar septa, and these lines will appear on the X-ray. Okay, other tests to be performed include electrolyte panel, potassium, sodium, urea. These are actually done for any patient. Also, renal function test, a liver function test. These are done as a baseline before you start your treatment, because your treatment will affect these systems. Okay. Now, what's next? After the heart failure has been put on the differential diagnosis list, after you did your BMB, ECG, chest X-ray, you are suspecting heart failure. How to confirm your suspicion? You actually do a transesophageal echocardiography. This is the most important investigation to be done for a patient with suspected heart failure. Any patient with suspected heart failure should have an echo, and preferably a transesophageal echocardiography. That is, the echocardiographic device is passed through the esophagus just behind the heart. This is the most important test because it will confirm the diagnosis. It will give a clue about the cause. For example, hypertrophy, decreased wall motion, valve diseases. Also, it will estimate the problem, the degree of the problem, by measuring the ejection fraction. The ejection fraction, we have discussed it earlier, is the ratio of the stroke volume, that is the amount of blood pumped out of the heart, to the end diastolic volume, that is the amount of the blood that reaches the ventricles before contraction. Ejection fraction should be above 50% for a normal patient, and this ratio decrease in heart failure. Okay. Now, echocardiography is the most commonly used method for measuring ejection fraction, but it is not the most accurate one. The most accurate one is nuclear ventriculography or the multi-gated angiographic scan. These are the most accurate method, but they are rarely used because the echocardiography is usually enough to estimate the ejection fraction.